The first talk that I'll be giving is on vulnerable populations, which we've already heard some of the issues raised in previous discussions. So I'll go through, largely in that talk, I'll be focusing on 3 case studies and drawing out some of the ethical issues that we've identified in those case studies thus far. This paper is still in its quite preliminary form at the moment. So for all of these, part of the goal of this has been to get your feedback on these issues. In this case, it's particularly welcome to hear what you have to say on the subject and the way that we're thinking about the issues so far. The second talk that I'll be giving is on gatekeepers. I haven't compartmentalized the two as much as the structure of my talks might imply and the structure of my slides. I'll just need to take a moment between the two to flip over to my slides that I've prepared for the gatekeepers section. So just bear with me for the 4 seconds or so that it takes to do that. Right, so thank you, and also forgive me for backing up from the microphone throughout if I do. I'm used to walking while I'm talking, so I'll try to behave. So for this, for the vulnerable populations, I just want to start off by identifying some of the questions that have come to surface for us thinking about this subject so far, and that have kind of gotten the focus in the paper as it stands at this point, and that have structured the way that we've been thinking about this. So some of the questions that have come up so far are, first, who are the vulnerable populations that we're talking about? What makes those populations vulnerable? From there, for those populations, can those populations give informed consent to participate in research is one of the issues that we're interested in, right? And in particular in CRTs. Another is, what are the ethical challenges that are raised? As we've heard today, not all of the ethical issues that are raised by vulnerable populations relate to informed consent, right? So just fleshing out what are the issues. And how should these challenges be addressed? So I thought it might be helpful when I was making these slides to sort of distinguish between the different things we're thinking about, who we're thinking about when we're talking about these questions. So one is from the perspective of investigators. Right? How should the challenges, the ethical challenges we identify, be addressed? Another is by research ethics committees. How should they be addressing the issues that are involved with vulnerable populations in CRTs? But there are also other groups who we've heard mentioned today, other stakeholders who are involved, such as funders, but we've also heard about other groups who might be implicated in research that involves vulnerable populations. All right, so to start with the first question that I had up, who are the vulnerable populations? So we've adopted thus far a fairly narrow definition of vulnerable populations. Right, so the first two that we're focusing on are children as well as incapable adults. The reason that I kind of have these two grouped together is that these are populations that I consider vulnerable in virtue of their diminished capacity, their diminished cognitive capacity at the time of decision making, at least, to make decisions about whether to be involved in research for themselves, right? So it may be temporary, it may be permanent, but for the moment when they're being approached to participate in research, their cognitive capacities aren't fully formulated, at least fully developed, in order to be able to make that decision for themselves. The other two groups or the way that I've come to think of the other two groups who may be vulnerable populations in CRTs are people who have diminished authority to make the decision about whether they may have diminished authority about participation in CRTs in virtue of the organizational structure they're in, right? So this could be prisoners, this could be military personnel, right? It could also be just people within other hierarchical structures, right, employees in institutions involved in CRTs. And then marginalized populations, so these are people who may have diminished capacity, they don't have diminished capacity, but they may have diminished authority or diminished freedom to decide for themselves whether to participate in research in virtue of the social structures in which they find themselves, right, so marginalized populations. So this could include these groups, not, Whether or not it necessarily does is another issue, perhaps, to discuss, right? But so those are who we're talking about when we're talking about vulnerable populations at this point. For children, so here's a case study. Here's one case study of a trial that involves one of these populations, that involves children. So this was an obesity prevention program that was carried out. So as you might guess from the reference to the fizzy drinks, this was carried out in the UK. This was a study that was designed to try to decrease children's consumption of fizzy drinks through an education program in the schools, administered in the schools, right, with the intention of addressing youth obesity issues. Here's a bit about the details of the trial. So, one-year nutrition education program. It was multifaceted, had various education interventions to teach children about the negative effects of drinking pop and the benefits of decreasing your consumption and drinking more water. In this case, so it involved 29 classes, right, which were the clusters that were randomized to the different interventions, to the intervention and control arm. And so in this case, consent forms were sent home to parents who then had to give consent to enroll their children in the trial. But all children, regardless of whether their parents agreed or not, consented or not, received the interventions, right? So they were recipients of the education programs. But for those whose parents didn't consent, they weren't subject to the data collection interventions, such as BMI, body mass index measurements, keeping a food and drink diary, and those sorts of things. Okay, so for this trial, so one of the strategies of this group has been to look at trials, CRTs, that it seems they might raise the ethical issues that we're interested in, and see if we can sort of get at the issues that arise and think about principled ways to address those issues. So here are some of the issues that might come up for you when you look at this trial. Maybe things like, in what ways are the children in the study vulnerable? What additional protections do they require in virtue of that increased vulnerability? Who has the authority to consent for what? For these, if these children are to participate in these studies? And it might be worth distinguishing between these different aspects of the trial, such as the nutrition education program, so the intervention that's carried out on them, that you might think of as the therapeutic intervention, versus data collection procedures, right? So here's a stab at some answers to those questions, but we're happy to hear your thoughts. So one thing is, so I've suggested that the children in the study are vulnerable in virtue of their inability to make that decision for themselves about whether to participate or not, right? So you might think that the 11-year-olds are kind of getting close to the age where they might inform these decisions at least, but the 7-year-olds maybe not, right? As a result, they have to rely on proxy decision makers others to ensure that they're not unduly harmed or exploited as a result of participating in this research. And so others have to make this decision for them. Typically, it seems likely that you go to the parents or guardians to make decisions about the children's participation and enrollment in the trial, which is what happened in this trial. Although what the parents consented to and were able to withhold consent, if they wished, was the data collection procedures, right? Not so much the education intervention. So just to foreshadow the next talk, school officials, it seems in this case, served a role as gatekeepers, and it was them who determined whether the children were going to be exposed to the research interventions in the study. And you might think that's fine, that the school officials are in a good place to protect the interests of the children, right, and the ways that their interests might be compromised as a result of being exposed to the research interventions and whatnot. But I think it's worth talking about whether or not that's the case, right? So one question you might wonder about and worry about is whether the school officials are in fact adequately informed to make judgments about how this is likely to affect school children's interests. You might also wonder about whether the school officials have interests that conflict with the interests of the school children, and might sort of be in tension with they're just making decisions exclusively on the basis of what's in the best interest of the children. And something else that you might wonder about is whether the parents in these cases actually have the freedom to choose whether their children are subjected to the education interventions, and whether parents' freedom to decide that doesn't in part hang on just sort of concerns. It doesn't raise concerns about justice, such as that parents have to be, say, in a good socioeconomic standing to be able to withdraw their parents from the classrooms, and probably involves withdrawing them from the schools in order to avoid subjecting them to the education interventions if they wish to. So they have to be able to afford to either relocate their kids to another school or stay home and homeschool them if they don't want their children to be exposed to the education interventions. Now on to another case study that involves another potentially vulnerable population, a CRT that involved prisoners, right? So in this case, the study, the CRT, was testing whether if facilities such as drug clinics and prisons where there's a high, there's potentially a high rate of undiagnosed hepatitis C virus amongst the population, whether introducing dried blood spot testing, in addition to what's often the only method of testing, which is venipuncture, could increase the frequency of testing amongst the population. So the intervention was designed to see if it could increase the frequency of testing by the staff in the prisons and drug clinics. Okay, so dry blood spot testing is just basically, I think of it as if you've seen people with diabetes, the little pinprick, it's a fairly, it's less risk, and it might be something that requires less expertise, arguably, to carry it out than venipuncture. So the idea was to see if you could get staff willing and trained to do this, whether that would increase the prevalence of testing of hepatitis C virus in these populations, in which there's a high risk and potentially high prevalence of people with undiagnosed hepatitis C virus. So 28 drug clinics and prisons were involved in the study. The initiative was, the intervention was carried out with respect to the staff in these facilities. So they were educated about a short counseling session, how to administer a short counseling session to the clients and prisoners about the risks of hepatitis C virus, how to carry out the dried blood spot testing, right? And from there, in the clinics and prisons that were assigned to the intervention arm, dried blood spot testing would be available, as well as the other standard mechanism for testing in the institution. In control arms, they would just stick with their regular standard method, right? So which typically was just venipuncture methods, which required a trained person who was willing to undergo the procedure, to perform the procedure, or even contracted out for periodic visits from somebody who would come in and do the testing. In one facility, the nurse consultant withdrew the facility because, quote, she fundamentally disagreed, so this is a report by the researchers, the investigators. She fundamentally disagreed that pre-test discussion should replace the longer duration counseling that she offered at their institution, and that discussion could be carried out by any clinical staff, so somebody who wasn't trained in counseling. Okay, so some issues that you might come up that you might think this raises are things like, first of all, as we've talked about before, who are the research subjects in this study? In what ways might those within the facility be considered as vulnerable? Who has legitimate authority in this trial to withhold or give permission to conduct the trial in these facilities? What are the ethical issues, or are there any, that are raised by the actual trial design? Right, because there have been some people who have taken issue with this trial, and others similar to it, just about the trial design itself that we can talk about. What are the benefits of participating in the research, and to whom? Do the inmates and clients of drug clinics have the ability to give free and informed consent to participate in the research? And so with all of these questions, as I said before, the ethical issues here aren't all to do with informed consent, right? But some of them have to do with it. So to start off with the research subjects, the question of who are the research subjects, arguably you might think that actually the prisoners and the inmates in this study aren't actually research subjects. So in the trial, there wasn't actually identifiable information that was collected about the prisoners and the clients in the drug clinics, right? But you might think that the employees of the facilities are. However, as I said, not all of the issues are necessarily related to informed consent, so you might think that there are other concerns raised by this trial. So for instance, we heard earlier about the need for vulnerable populations, the need to ensure that when they're involved in research, that the research kind of addresses needs that they have that are sort of particular to the research population, right? So if there's reason to suspect that there's a higher prevalence of undiagnosed hepatitis C virus, you might think there's some sort of obligation there, right, to be devoting more resources to increase in the prevalence of testing in those institutions. So as I said, we can talk about these things after in the Q&A, but that's just to flag one kind of broader social justice concern about the trial. So in this case, it seems like heads of facilities were chosen, that they were chosen as gatekeepers to determine whether to enroll the facilities or not. And so in this case, they're the ones who are determining whether to give permission or not to conduct the study in their facilities. And you might wonder whether that adequately protects the interests of the staff in the facilities that are involved, right? So earlier I mentioned that you could perhaps have populations that are vulnerable in virtue of their position within organizational structures. And so you might wonder whether there's reason for concern about the employees in the facilities and their freedom to agree to participate in the research or not. So the nurse consultant in the example seemed to feel free to withdraw and to object to the research, but you might wonder whether there were others who didn't feel so free. And by contrast, you might wonder whether she should have had the ability to unenroll the facility from the trial. So in the third case, I'm just going to go through fairly quickly. But in that case, that was a study that was carried out in India to measure an intervention that was meant to improve the health and the quality of uptake of appropriate care in India, in these places in India, through doing sort of empowerment, going through these what they called participatory cycle mechanisms. So the idea is to have groups coming up, have groups getting together of women within the communities, identifying issues that they face with respect to maternal care, and for them to do troubleshooting of the issues that they face, and kind of coming up with solutions, getting back together and giving feedback to one another about how these are working, how they're not working, and coming up with alternative strategies. So 36 clusters were involved, where women attended in the intervention communities, women attended these groups. So in both intervention and control communities, there was surveillance of neonatal mortality rates and maternal depression to measure outcomes. And mothers were approached for their individual consent, but before that, village representatives and various political officials were first approached for permission to carry out the trials in their communities. So some of the questions that you might wonder about here: in what ways are the mothers in this study vulnerable, right? What additional protections does this entail for them? What are the roles of individuals and gatekeepers with respect to the various aspects of this trial? Okay. And might there be challenges for the women in these trials to giving free and informed consent to participate? Okay, so a number of issues addressed by this. So I'm going to go fairly quickly through the protections so that we can get to the gatekeepers section. But I mean, some of the issues some of the ways that the issues have been addressed is by, it seems were addressed by employing gatekeepers in this case, so the village representatives were consulted, right? And one thing I think to note about this is that although it may raise concerns that gatekeepers may serve to prohibit research from going on in communities, important research from going on in communities, it might also serve to sort of promote the goals of the research within the community, and kind of and could potentially serve to empower members of the community, right, through, if you've convinced the leaders of the community that this is good research and got them on board, then kind of helping to promote it within the community. So the next part of the talk is going to be on these gatekeepers that I've been talking about and that we've been talking about today. And in this case, so we've written a paper in which we've come to some conclusions about the appropriate roles of gatekeepers and when it may be legitimate to use them. Okay, so I'm just going to go through briefly some of the things that we've come up with on that, and like I said, to hopefully get your feedback on this in the Q&A. Some of the issues that we're interested in are what are the goals that they may serve, that gatekeepers may serve, who may they consent on behalf of, and how can gatekeepers facilitate the ethical conduct of CRTs. So first I want to deal with the issue of the sorts of trials. So one of the examples we heard about earlier today was of trials that are meant to test the effectiveness of vaccination programs. So you have clusters being randomized to intervention or control arms, but the interventions themselves are being administered at the individual level. So in these cases, we propose that you may, although gatekeepers may give permission to randomize, right, at the cluster level, okay, and that may be fine, they're not well situated and they shouldn't be used to give permission to administer the interventions to the individuals in these cases. With rare exceptions that I'll note later, but those largely apply to cluster trials, so where the intervention is being administered at the cluster level as well. Right, so in CRTs that randomize at the cluster level but administer the interventions at the individual level, in those cases, so long as the individuals are research subjects, they meet the criteria of being a research subject, and the research isn't eligible for a waiver of consent, the individuals should be informed of randomization at the earliest opportunity and before any interventions are administered or any identifiable data is collected about the individuals themselves should be the ones to give consent to enroll in the trial. And presumably, so one reason for this is at a pragmatic level, if you're administering the intervention at the individual level, then that seems to suggest that you have the opportunity to obtain consent directly from the individual, right? Because there's that contact between the investigator and the subject. But also, in terms of, so sometimes the role of a gatekeeper in giving consent or giving permission to for an individual to receive an intervention is treated as akin to proxy decision making. We argue that the gatekeeper is rarely in an analogous situation, an analogous position to a proxy decision maker. So they're rarely that familiar with the interests of the potential research subject to make that call. So with respect to the role of gatekeepers in individual cluster trials or trials where the intervention is being administered at the individual level, rarely will it be ethically permissible for a gatekeeper to give permission for the individual to undergo the interventions. With respect to CRTs where the intervention is being administered at the cluster level, in some fairly rare situations, or we think they're probably fairly rare, it may be possible for a gatekeeper acting as a representative on behalf of the individuals in the cluster to give permission to undergo the intervention, right? And those are cases in which the gatekeeper has legitimate democratic authority to make that decision. So what does that mean? Okay, so first, just the note that it has to actually be infeasible, and we've talked about the issues that raises, but still, it has to not be feasible for to get consent from the research subjects in these cases. That makes it necessary to go to gatekeepers. But the conditions for democratic legitimacy are, so first, when someone's been appointed, right, and has accepted that role, that seems like one condition that you would need to satisfy for this person to have democratic legitimacy. The second is that the role of the representative, right, the way it's defined, clearly actually confers authority over the decision at hand. And lastly, that the members of the constituency actually accept the authority of the representative in that role. So it's only under those conditions that a person, a gatekeeper, will actually have the authority, legitimate authority, to sign the cluster up for a CRT. So other roles, however, that the gatekeeper may serve aside from giving permission to participate in these things are that they may facilitate cluster consultation. Okay, so they're not giving permission, but they're facilitating the more ethical conduct of CRTs by facilitating the cluster consultation or consultation between investigators and the members, potential research subjects, about things like study design, implementation, and perhaps dissemination of research results. Also, they may serve the role of protecting group-based interests. So in cases where the research involves groups who may have distinctive group-based interests, so we've heard some talk about this already, where it seems like the outcomes of the research or the research itself could be detrimental to the interests of the members of the group, but in virtue of their belonging to a particular group, right? So maybe because it has the potential risk of increasing stereotypes or stigmatization of the members of the group, right? In those cases, gatekeepers may be used to help protect the interests, these group-based interests, right? In virtue of being approached to give permission, in virtue of giving permission to approach the members of these groups. So for instance, in organizations such as hospitals or schools or classrooms, communities, or subpopulations within any of these groups. And last one, your stamina is amazing. But the last one is that gatekeepers may serve the role of identifying potential research subjects for investigators, right? So in some cases, gatekeepers may facilitate investigators in finding research subjects who are eligible for the study or who may be eligible for the study. So in some cases, physicians, right, are approached to identify potential research subjects. An important point to bear in mind when we think about this is that you cannot presume, however, that just because a gatekeeper is serving the role of identifying potential research subjects, that the gatekeepers necessarily are serving the role of protecting the interests of those potential research subjects. So in some cases, if it's involving a physician, you might think that the physician, yes, does serve the role of protecting the interests of potential research subjects, but it's in virtue of that being part of the role of a physician, right? So we've talked about the fiduciary obligations in Charles's earlier talk, right? Where that is part of the physician's role as a physician, is to protect the interests of her patients. However, there have been other studies where an index member of the group has been chosen, and investigators have asked that member of the group that they want to do research involving. So research involving HIV, men with HIV. In those cases, the research, the gatekeeper shouldn't be relied upon to be protecting the interests of the potential research subjects. It would be nice if they did, but it's not part of their inherent role, right? It's not an essential aspect of their role, right? In part, they may not have the knowledge base, which a physician is supposed to, and so it's not part of their defined role as such to protect the interests of the other potential research subjects. So it's a completely contextual sort of call whether they're going to do that or not. So that concludes the two talks on vulnerable populations and gatekeepers. So I welcome your comments and discussion.